My name is Michele Tardivel, and I'm very happy to be your moderator this morning. I'm the managing partner at Earl's Pharmacy here in Saskatoon, a member of the Rubicon Pharmacies group. I obtained my BSP from the U of S in 1990 and have worked at Earl's Pharmacy ever since. Earl's specializes in looking after pharmacy services for many of the long-term care homes in and around Saskatoon and has done so for over 40 years. We are pleased to offer this continuing education and development for nurses College of Nursing event in cooperation with the Ministry of Health. Please make sure that you sign in with your email address today. If you don't sign in, you won't receive your certificate of attendance from the CEDN. There will also be a draw for door prizes after the e-learning for all our participants, so make sure to sign in and ensure that your email address is legible. Today's event is being transmitted live to 15 sites with over 90 participants throughout Saskatchewan. Thank you all for joining us today. We are live from Studio B in the Education Building, University of Saskatchewan. This signal is being streamed to sites across the province and computers via eCast. You can see us and hear us, but if you want to join in the conversation, you will need to call or text us. As you can see in the agenda, you'll have the opportunity to share your comments and your questions, so please ensure that you jot down your questions and comments and phone or text them in throughout the morning. Also, this is a self-facilitated event, so you may want to appoint a recorder or facilitator to document your questions and call or text in from your site. Here are the numbers that you will need. To call us at the studio, the number is 306-966-8800 and text us at 306-220-0462. Your texts help to ensure that a variety of questions are answered, but the phone-in questions really provide an opportunity for dialogue. The studio audience here in Saskatoon is also invited to ask questions by using the microphone. We hope to hear from all of you. Just a reminder before we get started, because this workshop is being telecast, it's important that everyone is diligent about the time, especially here in the broadcast studio. We ask for your cooperation in returning from the break a few minutes before we go back on air. The cameras start rolling precisely at the times listed on the agenda. Are you all sitting comfortably? Let's get started by introducing our wonderful speakers. Julia Bareham is a pharmacist who works with the RxFiles Academic Detailing Service Long-Term Care Project. She is a graduate of the U of S and completed her Master's in Science in Pharmacy in 2014. Julia also chairs the board for the Pharmacy Association of Saskatchewan. Dr. Brian Martens is a GP working in Saskatoon. He graduated from the University of British Columbia Medical School in 1987 and has been involved with long-term care for over 20 years. Welcome, Julia and Dr. Martens.
Thank you very much, Michelle. So we'll jump right into it. And I wanted to start off by sharing with the audience a little bit about RxFiles. And the reason I want to tell you about RxFiles, the program that I work for, is because RxFiles has a variety of resources that I think you'll find useful and practical and that you may want to access if you're unfamiliar with them. So what is RxFiles? Essentially, RxFiles is an academic detailing program, which means we provide education to healthcare professionals in Saskatchewan. We are a not-for-profit program. However, we do sell some of our products outside the province, and I'll tell you a little bit more about that in a few moments. We get a grant from SaskHealth to operate, and we do have to reapply for that grant every few years. And we've been around since 1997, and we began as a service specifically for family physicians here in Saskatoon. Essentially, RxFiles exists to support healthcare professionals in making the best possible drug therapy choices for their patients. And we really find value in providing balanced perspectives on drug effectiveness, safety, cost, clinical evidence, and patient considerations. So essentially, RxFiles resources will never tell you, do this, do that, this is right, that is wrong, but rather provides you with the information you need to make a good, evidence-based, well-informed decision for that patient who's right in front of you, because we know every patient has different considerations we have to put into the equation. Over the years, RxFiles has evolved. So while we began in 1997, in 2000 we actually expanded beyond Saskatoon to serve physicians across Saskatchewan. And then in 2001, the resources we were creating became so many that we put them into a book that we call the Drug Comparison Chart. And I'm going to show you that on the next slide as well. And then finally in 2011, we received additional funding to expand to provide services into long-term care. And all throughout this process, we've gone from physicians to pharmacists and nurses, and especially with our focus on geriatrics and long-term care, nurses are at the forefront of resident and patient care. So we've started to provide more education to this population. So here on the slide, you will see our RxFiles comparison chart. This is our claim to fame, if you will, amongst physicians and pharmacists specifically. This is also the door prize that you can enter to win. This book is available in print, of course, on our website, and as well as an app. And again, I'll tell you a little bit more about that. When you open the book, what you'll see, and you'll see it on the slide here, is a very busy page, and I'm sure you can read every word on there from where you are currently. So it's very intimidating. Lots of small print, lots of information. And the reason it's so small and there's so much there is this particular slide shows you lipid-lowering therapy. So on this page is every medication available to lower cholesterol. What chemical names exist, what strengths are available, is it even covered by the provincial or federal drug plans? How effective is it at lowering cholesterol? Drug interactions, monitoring considerations, contraindications, appropriate dosing. Do you need to adjust it in renal or hepatic concerns, and even a cost comparison? All available on one page. So I really encourage you to go check it out, see what you think. It takes a little getting used to, but it's a great one-stop resource when you're looking for some quick drug-related answers. But RxFiles is more than just those busy drug charts. We tend to serve healthcare professionals with things such as newsletters, which takes our information, puts it into prose, so in sentences, in a 1 or 2 pager sort of document. We have Q&As. Maybe there's a hot topic you're wondering about, so we'll also describe that in a 1 page. If you're really into the evidence, we have trial summaries available, and as well, we always update our charts online. So we have all sorts of tools for the frontline practitioners wanting to provide the best possible drug therapy to their patients. And if you go to our website, rxfiles.ca, you'll find these tools. So let me show you what the website looks like. So on this particular slide, I'm showing you our long-term care tab. And if you work in long-term care or if you work with older adults, this particular portion of the website might be of greatest interest to you. You'll see near the bottom, there's 3 rows divided by healthcare providers, long-term care administrators, and residents and families. And when you click on those individual tabs, it'll have a drop-down menu with a variety of resources. And the great part about the long-term care tab, which we actually created in collaboration with CADIF, another evidence-based organization, is that we recognize that there are some great resources out there, and why recreate the wheel? So we've linked to other evidence-based balanced resources that you might want to send your colleagues or maybe your patients or their family members to as well to find good quality information. So how much is it to access our website resources? Well, are you a healthcare provider in Saskatchewan? If yes, then it's free. So there's 3 ways to access RxFiles resources electronically. The first is through SHRP.ca, so that's the Saskatchewan Health Information Resource Program, and they have a variety of resources, over 6,000 medical journals, all sorts of great resources there. I highly encourage you to go there. Again, free membership for healthcare providers in Saskatchewan. If you use PIP, the Pharmaceutical Information Program there's a tab that says references, and you can access RxFiles for free. And as well, if you're in a health region, you should also be able to automatically log into our website. And just in case you like to carry around a tablet or a smartphone, there's an app for that, for both Apple products and Android products. The one catch is with that is that's the one thing we cannot provide for free to the healthcare providers of Saskatchewan, because it is managed through either iTunes or Google Play. But wait, there's more. RxFiles, because we're an academic detailing program, we will come to you. We will go anywhere in Saskatchewan. We can do it in person, or via telehealth, which is often more economical if you're in the very northern part of our province. And we have a variety of topics to discuss. And even though it sometimes is a long drive across our great province, it's important to never travel alone. And sometimes you'll see me driving around with my friend Bones Apart Skellington, just so I don't get too lonely on the highways. So if you want to know more, please don't hesitate to contact me. I've placed my email on the slide here, so it's often easier to remember, julia@rxfiles.ca. Again, don't hesitate to contact us with any information about the program or even about the talk that we have today. So now let's move in to optimizing medications in older adults. I'd like to start with a patient case. So let's pretend before us we have an 82-year-old female. She has hypertension. We look at the chart, it's essentially long-standing. She also has depression on her chart, also states it's long-standing. She tells you she has some constipation, and when you query her a bit further, she says, the last few years I've struggled. She also has osteoarthritis, and it mostly affects her knees. She has some sleep complaints. Again, you ask a bit more, and she says, again, the last few years I've struggled with my sleep. She also says, I've noticed in the past few months my memory is just not what it used to be. You go on further and you see there's some urinary incontinence, and that was diagnosed about 8 years ago. And she also has type 2 diabetes, only diagnosed 3 years ago. Further into the patient chart, you might notice that her serum creatinine is 112 micromoles per liter. She's 152 centimeters tall. She weighs 65 kilograms. And someone has been kind enough to come in before you and calculate the estimated renal function, and you see that it's 35 mils per minute. You notice you don't have any cholesterol levels, but her blood pressure is sitting at 127/72. So with this information you have before you, for myself when evaluating an older adult, one of the initial steps that I do to ensure that the individuals getting the most appropriate medications is ensuring that the dose is appropriate based on their renal function or kidney function, assuming the medication is eliminated through the kidneys, something that is noted in our RxFiles charts if you're ever wondering. So how do we figure out kidney function or renal function? Well, again, in a world of smartphones, there's an app for that. And I've just got the one on the screen that is for iTunes or Apple products, and I'll show you an Android one in a moment. But what you see in this particular app is it allows you to enter that serum creatinine level, the age of the patient, their weight and their height. Then you also choose sex. And then what it will do is it will give you 3 different calculations of renal function. Your CKD-EPI, which is probably the most accurate measure of kidney function in an older adult. You get your MDRD, another way of calculating renal function. And then finally you get your Cockcroft-Gault, which is the only formula validated for dose adjustments. And then here is the app available for Android phones, very, very similar. It's from the National Kidney Foundation. Both are free, and it just allows you to quickly make that calculation to figure out what the estimated renal function of your patient is. So I just wanted to ask Dr. Martens how he approaches renal function in his clinic.
Well, I'm old enough to say that many years ago we didn't pay as much attention to it as we needed to. And certainly it is a very important measure to know whether or not you're giving the right dose of medication to a patient. And in the Saskatoon Health Region, for about the last 2 years, they've been publishing, when you do a serum creatinine, an estimated glomerular filtration rate as well. It's based just on the sex and the age of the patient, so as you can tell, that's not going to be a terribly accurate measure. And it's not exactly the same as creatinine clearance. They vary by about 10%. Now, there's all kinds of different formulas, as Julia was talking about, to calculate creatinine clearance. And I looked up a bunch. There's the Cockcroft-Gault, which is the main one that we used. There's also something called a Dubois and Dubois, the Schwartz estimate, and Gahan and George formula. They are all estimates, okay? And we shouldn't get too fixated on it. I have a little app on my iTouch which calculates it for me down to 1/100th of a mil per minute. Really? I don't believe that. It's an estimate. But it is an important thing to really keep an eye on. just last night. A family member, she's been struggling with a urinary tract infection. She's on a medication. She's feeling sick. Upset stomach, nausea, just not really getting better. Did some checking, found out that her serum creatinine came back at 69. Hey, great, not a bad number, no big problem. But when you factor in weight and age, turns out that her creatinine clearance is running around 56. Actually, my calculator said 56.71, whatever. But she's on macrobid, which is a problem if you start getting below about 60. So in my mind, this is a sort of borderline case, and maybe some of her symptoms are due to the medication. A nice serum creatinine does not mean that everything is fine. So, and I think you're going to go back to the case at this point?
Yeah, just before we do, I had a couple questions, and I wondered if you noticed that things like dehydration can really affect that renal function?
Anything that changes a serum creatinine changes the creatinine clearance. And so what I've told some people, if you don't like the number you just got, do it again, it'll be different. But certainly if they're dehydrated, that will make a big difference in terms of what kind of numbers you get.
Yeah.
I've got one lady who's on Xarelto, and yeah, she's sort of a borderline case for it, and her serum creatinine is running around 35. If she gets dehydrated, it's 28, so I tell her to drink a bunch of water and then let's do the test again. So, because 30 is the cutoff. But remember, these numbers are estimates.
Right, and many limitations to those formulas,
Yes.
especially those who may be obese, amputations. The extreme ages weren't included in the study, so I think it's a great point that you emphasize that it's just an estimate. All right, well, let's go back to that patient case. So we have our 82-year-old female, and here are the medications she's taking. So Metformin 500 twice a day. She's on a low-dose aspirin once a day. She takes atorvastatin 20 or Lipitor, sertraline or Zoloft 50 milligrams daily. She's taking Colace or Docusate 100 milligrams twice daily as needed. She's on the oxybutynin 5 milligrams twice a day. Amitriptyline 25 milligrams at bedtime. She takes hydrochlorothiazide 25 milligrams once a day. Ramipril or Altase 10 milligrams a day. And Zopiclone 7.5 milligrams daily. And of course, she shows you that on that nice little printout that the pharmacy gave her. Then you ask her quickly, is there anything else you're taking? Oh, I take a few other over-the-counter products. Perfect. So sometimes I just like to sit back and look and see if anything sort of jumps out at me from this list. I dare say for an 82-year-old, she's not too complex. And it's a pretty standard drug list for someone you might see living in the community. So keep in the back of your mind if there's anything that jumps out at you that you might question further or may want to adjust, because we'll go through it as we go through the presentation. So she's sitting there before you, and you ask her, what are your concerns related to your medications? Of course, you frame that with a nice open-ended question to see what the patient will tell you. And then she replies to you, well, I want to take fewer medications. I often wonder if I need all of them, and it's costing me a lot of money each month. $20 per prescription, that really adds up. So when you get that comment from that patient before you, where do you go from there? What we hope to do now is share a lot of tips on assessing those medications and ideally optimizing them for your patient. So the first medication tip that I have is the brown bag method. What you want to do is line up medications with an indication. So here you're taking this medication, why are you taking it? But don't assume you know why they're taking it. Be sure to ask, because often we think, oh, Altase, it's because you have high blood pressure. Well, perhaps they don't have high blood pressure and they recently had a heart attack. So things you just want to ensure you know why they're taking it. And watch out for prescribing cascades with this brown bag method, which again, I'll explain in a bit more depth on the next slide. But a prescribing cascade occurs when a medication causes a side effect. And that side effect is recognized as a new condition rather than as a side effect of a medication. And as a result, we treat that side effect with another medication. So a good example of this would be amlodipine or Norvasc. commonly known to cause edema or swelling of the ankles. So we have someone with high blood pressure, we put them on amlodipine, then their ankles start to swell. What do we do for swollen ankles? Well, we add furosemide or Lasix. What happens after we use furosemide and Lasix for some time in some people? Their potassium goes down. So now we start them on a potassium supplement or slow K. Where if we just would have gone back and recognized amlodipine is causing this edema and either adjusted the dose or changed the agent, we could have avoided the addition of furosemide and of slow K. So always be on the lookout for those prescribing cascades. And whenever an older adult presents with a new symptom, always suspect a drug or a drug side effect before you suspect that it's a new condition developing. So a little bit more about that brown bag review of medications. What is it? What we want to do is encourage our patients to bring all their medications and supplements to their medical appointments. Go home, grab every medication you have, place it in a bag and bring it to me, and let's go through them. So it provides clinical staff with an opportunity to review and discuss the medications with the patient to see what they're actually taking. And reviewing your medications with your patient, actually having them in the hand and going through each container or vial or box, allows you to answer any questions the patient may have. Quite often, someone doesn't know why they're actually taking that particular medication. You can verify what the patient is taking. So what are you taking and how are you taking it? Perhaps you weren't aware of some over-the-counter products. Perhaps they're really not taking it as prescribed. Well, I really didn't think that atorvastatin was doing much. I don't feel any different when I take it, so I probably take it 3 times a week. And that's really important in assessing adherence, because if we assume someone's adherent and taking their medication every day, but they're not, and they're not at target, we may add on a therapy unnecessarily. Again, because we assumed they're taking it and the medication maybe just wasn't working. It allows us to identify and avoid medication errors and drug interactions, again, especially with over-the-counter products that we may not be aware that that particular person was taking. And when someone really understands why they're taking a medication, how to take it properly, and the benefits, it helps them take it correctly and has been shown to improve adherence. So it assists patients to take their medications the right way. So if you look at the slides here, here's my brown bag that I asked one of my patients at the Geriatric Day Hospital here in Saskatoon to bring in one day. And when he opened it up and placed it on the counter, what you'll see on the slide here is a big plethora of natural products. This actually isn't all of them. These are the ones I took away to discard properly. And you'll see different dosing devices there, little dosettes with a variety of medications. And if you could see the detail of the photo, you can even tell that these products came from different merchandisers. So they weren't going to one pharmacy and getting all these products from one pharmacist. They were getting them everywhere. And this particular individual couldn't really rationalize why they were taking them, just thought they should. And not only is this a lot of medications to take on a daily basis, my concern was the cost associated with them, because those natural products can often be very costly, and older adults are often the target of marketing for these products. So I wonder, Dr. Martens, is this something that you use in your practice?
Yes. Brown bag review is something that I've done. The first few times that I did it, I asked them to bring their pills in, and it was rather discouraging when they came in with one big bottle with all their pills in it, which you're looking at a kaleidoscope of colors and shapes, and all I can say is I have no idea what the little white one was, okay? And looked pretty. The red ones were quite nice, but I have no idea what they all are. Questions that you also learn something by sometimes what kind of bag that they bring it in. Sometimes brown bags are getting harder and harder to find. Usually it's a shopping bag. No, you find out where they shop. And so you get to know your patient a little bit with that too. I asked them, did they bring in everything or just the stuff that I ordered? Okay, because sometimes that's all that they do. Did they bring in medications that came in from MECs? MEC is my abbreviation for Minor Emergency Clinic, not Mountain Equipment Co-op. I've had patients who've been to a minor emergency clinic, and after just one visit, one blood pressure taking, we're put on a different antihypertensive, which is always a little bit scary because I might not ever get a report from that clinic about what they did. And suddenly I find out somebody is on Norvasc 10 milligrams once a day. That's a concern. Herbals. That's something that is an area we are kind of unsure about what to make in terms of interactions and so forth. The bottle always says consult your doctor. Talk about the blind leading the blind. There are resources, especially here at the U of S, where you can contact people to get some information on some of these. Often, not a lot is known about them. Ask them, how often do they take this stuff, as Julia was talking about. Many times they're very open and honest about it, and that's great. I'm not angry if they don't take it as often as they should. I just really want to know. And sometimes when you're looking at the bottle, you're checking to see how often it's refilled. The 34 pills once a day that took 12 weeks between refills. Well, you're obviously not taking it every day. There's also this concept that I have of intelligent non-adherence. That's where the patient comes up to me and says, Doc, if I take that pill that you told me to take every day, I feel sick. But if I take it twice a week, it's okay. And you know what? For some pills, that might be okay. Anti-inflammatories, it's a pain medication. If they're not having pain, maybe they don't need to take it every day. And so sometimes that's quite reasonable. Iron pills. Many times seniors have a great deal of difficulty absorbing the iron, and taking 3 iron pills a day is just torture. Probably, maybe even, I have told many of them just to take 1 pill 3 times a week, just so their stomachs are feeling a bit better. And I've also run into the case of the senior who comes into the office, smiles very nicely, nods appropriately, takes the prescription, goes to the pharmacy, buys the pills, goes home and flushes them down the toilet. And I usually find out about this from daughters, okay? They're the ones who tell us about it. And why is that a concern? Well, they seem to be filling their medications, everything seems to be in order, but if they ever go into hospital or into long-term care, you got a disaster popping up because they're not taking the drugs the way you thought, and they're going to run into trouble when they get into hospital. So yes, it is a useful thing. Yeah. Definitely do it. And it is kind of fun. You get to know your patient a bit more.
Yeah. I think it's a great opportunity to identify those expired medications, and instead of them being flushed down the toilet, hopefully dispose of them appropriately at the pharmacy. I've even seen the wrong things in the bottle. Sounds like you've seen them all in one bottle, which can of course lead to inadvertent misdosing. And those herbal products, again, sometimes it's really hard to read what's actually contained in that product. There are products with natural product numbers, which should be regulated through Health Canada, but often it's hard to maybe find out what exactly is in there. And I find, again, that brown bag method is a great opportunity to sit down with that individual, tell them about what's in that product, inform them about the benefits and the risks, and ensure they're making the best decision for their health. So moving on, I wanted to move into 2 concepts that I think are very important when evaluating medication therapy in older adults. And that's time to benefit and risk versus benefit. So let's start with time to benefit. So time to benefit is useful to consider in this situation how long an individual likely has to live when considering a drug therapy. Now, none of us have a crystal ball, and anytime we guess, we'll probably get it wrong, but often an educated guess related to someone's age, their comorbidities, their frailty levels is always good to have in the back of your mind. Because you need to consider situations where the benefit of a medication is only realized after several years of treatment. And if the time to benefit is equal to or less than life expectancy, then that medication is really unlikely to benefit that individual. But the question then becomes, how long does it take to achieve a benefit with a particular medication? So what is the time to benefit of treatment? So when we look at this 82-year-old female patient in front of us, we know that she was diagnosed with type 2 diabetes 3 years ago. So what is your glycemic target for this particular individual? Are you aiming for an A1C of 6.5, Perhaps an A1C of 7? Or are you aiming for an A1C of 8.5? Well, the question is, what are we trying to achieve in treating this individual and her diabetes to a particular A1C? So what are the big outcomes that we're aiming for? So really, ultimately, why do we strive so hard to control someone's blood sugar levels? Well, really in diabetes, it's about macrovascular and microvascular outcomes, such as we want to decrease cardiovascular events like heart attacks, stroke, cardiovascular death, and heart failure. We want to decrease the chance of all-cause mortality or death. We want to keep them out of the hospitals. We want to decrease new onset or worsening of nephropathy, so we want to keep their kidneys happy and healthy. We want to decrease retinopathy. We want to keep their eyes as healthy as possible. We want to decrease neuropathy, keep those nerves working as best they can. And of course, we also want to decrease foot care complications. So that is why we treat blood sugars in diabetes. But what does the evidence tell us about how long it takes to avoid those outcomes that we're trying to prevent, like again, cardiovascular concerns and nerve damage? Well, some examples from the evidence specific to diabetes and time to benefit are these two studies you see before you. So the first one I want to highlight is a UK PDS 34. And in this particular study, it was metformin versus standard treatment in obese type 2 diabetics. And what they found was a decrease in all-cause mortality, and the number needed to treat was 14 over 10.7 years. So what that means is we have to treat 14 people in order to decrease all-cause mortality in one person over 10 years. The lower the number needed to treat, the better, right? We only have to treat a small amount of people to achieve a benefit. We also saw a decrease in stroke with a number needed to treat of 48 over 10.7 years. And here in this particular study, the A1C achieved was 7.4 versus 8. So this was a 10-year trial that it took to see decrease in death and decrease in stroke. The other trial, the advanced one that's listed on the slide, was mostly glycoside or diamicron plus or minus metformin. And in this particular trial, they saw a decrease in those microvascular events. Those are your kidneys, your eyes, your nerves, with a number needed to treat of 67 over 5 years. And in this particular study, the A1C was 6.5 versus 7.3. One caveat to the advanced trial is that the average age was 66. So I kind of group my older adults generally starting at 65 and older. So these aren't our old individuals. But what it tells us is it takes about 10 years of adequate glycemic control to achieve a macrovascular benefit, so those cardiovascular concerns, and it takes about 5 years of treatment to achieve benefits with those microvascular complications. So if you're ever looking for other information related to the time to benefit for various health conditions, you can go to the RxFiles resources and find this chart that you'll see on the slide. And I'm just going to blow it up a bit because, again, always hard to see. So here you see type 2 diabetes, where we highlight right at the top, abbreviated T2B, about 6 years for microvascular complications, 10 years for macrovascular. You go down to heart failure. As little as 6 months of treatment with ACE inhibitors can decrease mortality. Hypertension, about a year of treatment. For lipids, it takes about 2 years to benefit. And then down in osteoporosis, we see 1 to 3 years for fracture prevention. So if you're anything like me, sometimes you find it difficult to remember things unless they're written down. And this is why I share the RxFiles resources with you, so you know where to go and find that information in the future when you're trying to remember all the little details. So the next topic I want to move into is guideline targets. So let's look at diabetes again. So here we have glycemic targets. And I think it's important to note that there are no studies specifically assessing the risks and benefits of tight glycemic control, so going for those lower A1Cs, in individuals who are 75 years or older, or frail elderly individuals. So all the data we have is extrapolated from trials in younger patients, where the mean age is often in their 60s, trials like the Accord, Advance, and the Veteran Affairs Diabetes trial. And that's a challenge quite frequently in older adults, that these are the people who are not making it into the study. So we're sort of extrapolating or assuming that what happens in younger adults may also occur in older adults. But of course, that's when we encounter frailty, which complicates things. So not many guidelines are addressing older adults, let alone frail older adults. But in 2013, when the Canadian Diabetes Association put out their new guidelines, they did actually address frail older adults. And the table that you see, you will see a differentiation between healthy older adults and frail older adults in terms of their target A1C, as well as the fasting plasma glucose or postprandial plasma glucose levels. So how do you define older adults? Generally, and in these particular guidelines, they define it as someone with multiple comorbidities who likely had a life expectancy of 10 years or less. And it's in that group when you can start to back off on those stringent targets, which makes sense when we think about the time to benefit of treatment. So if it takes 10 years to achieve a big macrovascular outcome, then if someone has less than 10 years of expected life left, we can probably start to loosen those targets a bit. But as we loosen these targets, we need to put at the forefront of our treatment, our priority is to avoid hypoglycemia. And the risk of severe hypoglycemia increases 2 to 3-fold when we sort of strive for those tighter glycemic control, when we try to get them down to that A1C of 7. That's when we run into trouble. And we know that hypoglycemia has been associated with increased morbidity and mortality in diabetes, because what happens is folks fall more, we see cognitive decline, we see autonomic dysregulation and cardiac effects. So in studies where the A1C was as high as 7.9 to 8.4%, and you see the guidelines are saying we could probably go around 8.5, we've seen marginal clinical outcomes over the short term, but more importantly, much less risk of hypoglycemia. So again, the prevention of hypoglycemia in older adults with diabetes becomes the primary goal of treatment, especially when they're frail. And then our secondary goal is to deal with that symptomatic hyperglycemia. Because when our sugars are too high, our body's trying to expel them, and maybe we need to pee more, for example. And older adults often struggle with sleep and maybe nocturia, and it's a great opportunity for a fall when you've taken your sleeping pill, it's late at night, you're tired, and you need to pee. So it's something we also need to certainly concern ourselves with. So if you have a frail older adult, especially someone who might be in long-term care, and you do an A1C and it comes back less than 7, that should be a flag for you that they are possibly overtreated. And we should start to consider stopping, if not reducing, medications. And a great place to start are those medications that are known to cause hypoglycemia. So metformin's a pretty good one, but a sulfonylurea like gliclazide can cause hypo. So that's where I would start, is starting to get rid of those particular medications. So perhaps you're wondering who might be the best person to loosen or back off on that target with. So when it comes to glycemic targets, here are a few considerations when looking at that particular individual in front of you. So do they have a limited life expectancy? And in diabetes, it's at 10 years or less. Do they have functional dependency? Do they need someone else to help them with their activities of daily living? Do they have extensive cardiovascular concerns, coronary artery disease? Are they at high risk of cardiovascular events? Because these are the folks that we definitely don't want to go hypoglycemic. Do they have multiple comorbidities? Do they have a history of recurrent severe hypoglycemia? And often in older adults, especially older frail adults, hypoglycemia may present differently than in a younger, more robust individual. Are they completely unaware when their sugars go low, putting them at greater risk for a fall? And what available resources and supports do these individuals have to treat their sugars and better control them? Are they able to inject themselves with insulin, check their blood sugars, and other considerations such as that? So I'll throw it back over to Dr. Martens for his thoughts.
Glycemic targets. What I'm going to be talking about here is, of course, the type 2 diabetic, which is the majority of what we see. And this is also the part where I'm probably going to get into trouble. I am not a big fan of guidelines, and I must confess the diabetic guidelines are the ones I've always found the most annoying, mostly because it took so long for them to change. There is not a lot of evidence of benefit with really tight control. The Accord, the Advance, and the Veterans trial did not show much in the way of help in terms of reducing death when you really try to control sugars tightly. In fact, the Accord trial was stopped early, at least in that part of it, because of an increased death rate. Hypoglycemia, as Julia says, that's the problem that you're going to run into. And if you try to get it down below 6.5, you're going to cause problems because you're going to have to use so much drugs to get it down to there that you're walking so close to the line that these people are going to run into trouble. There is definitely evidence of benefit of microvascular complications, but when I look at the numbers, number needed to treat over 5 years of about 67 or so, I'm more concerned about them dying, okay, or falling or whatever. And so definitely, as Julia says, when I see them coming in with a hemoglobin A1C of 6.7%, well, let's start slashing, okay, because we don't need to be that tight. I do go after insulin, reducing that one first because that's the one that scares me the most. It's a drug that can kill you, and certainly we try to get that one down. Metformin, so far to my knowledge, it's the only oral hypoglycemic agent that's been shown to reduce cardiovascular mortality. And so that's the one that's also the least likely to cause problems in terms of low sugars. And that way, that's when I would like to leave on at least even giving them a pinch of it to the very end. There's a possibility that maybe over time, tighter control or better control improves outcomes. The thing that's very frustrating to me is when you have to study an awful lot of people for a long time to see a benefit, it tells you that the benefit's not going to be very big, okay? There was a study that I don't have the reference for, but where they looked at seniors, the length of time it took for seniors to get into long-term care facilities, diabetics, type 2s, and their average hemoglobin A1Cs. The people who had hemoglobin A1Cs under 7 went into long-term care the fastest. Those who were around the 7 to 8.5, they took the longest to get into long-term care. And then the ones above 8 were also a little bit faster to get into long-term care. So there is a benefit in relaxing things a little bit, especially in your seniors, because that hypoglycemia is what can really cause problems. Falling over in the middle of the night and hitting your head on the toilet is not good, okay? Now, and we got to be careful when patients enter hospital. I had a patient approximately 6 years ago, the first time I ever saw her in my life, 83 years old. First time she ever came in to see me, she was in the middle of having a heart attack. Chest pain, sweating, shortness of breath. Ship her straight over to RUH, she gets in, diagnosed with an MI, all that sort of stuff. Lo and behold, her sugars are also up in the 20s, okay? Not known to be a diabetic. Wham bam, she's on insulin, which is totally appropriate in the hospital. I have no problem with that. When she was sent home on hospital, she kept having hypoglycemic episodes. And over the next 3 weeks, the home care nurse and I were in contact probably about every 2 days. She's running into 3s and 2s and sweating at night and so forth. We kept slashing the insulin down until finally, just stop it. She's now on metformin, about 250 milligrams twice a day, and her sugars are great. So under stress in hospital, their sugars are going to be high. When they get out, don't be surprised if they need less medication. And be careful about that, because we can kill our seniors much faster with hypoglycemia in these sorts of situations. About a year ago, I was at a conference, and there was a speaker named Ron Hayward from the States, and he's a person who's very interested in lipids and guidelines and all that sort of stuff. Anyways, he made the comment that for your type 2 diabetics, The most important thing is to make sure their blood pressure is good. Then make sure they're on a statin. Then check their blood pressure again, make sure it's okay, and then make sure that they're on a statin. Only after a while do you start sugar control is the third one in that list, and it's got the, as far as macrovascular complications, it's the one that has some of the, sugar control has some of the least evidence. Yes, probably over time it increases. Yes, I think it's important, but we need to focus on some other things and also worry about danger, especially in our seniors. We can kill them, and we got to be careful about that. It's not a good thing to do. So, but anyways, that's it. I probably get in trouble for that because I know some people are very concerned about following guidelines exactly, and I become rather discouraged with them.
A guideline's just a guideline.
I know,
It's not a hard rule.
I know, but some people view it as gospel, so.
I really like your point about being in hospital and being stressed and having increased insulin requirements, because so many of us receive those patients back in the community, whether it's long-term care, whether we're a home care nurse, whether we're a community pharmacist. And what a great opportunity to be just that much more vigilant in checking those blood sugars when we get that discharge summary. So great tip, you got me thinking already. So now to make everyone else think, I'd like to go back to that second concept I alluded to, risk versus benefit. Have you ever asked yourself, how well does this medication even work? I don't think it's a question we ask often enough. So going back to our 82-year-old female patient, remember she's on oxybutynin 5 milligrams twice a day. This is an antimuscarinic or anticholinergic medication. And anticholinergic medications, which I'll go into a bit more depth in a couple slides, can cause a lot of problems for older adults, especially cognitively or in terms of their memory. And what we do know by that chart is that she's had urinary incontinence, and it was diagnosed about 8 years ago at age 74. I don't think that's that uncommon of a scenario to encounter. Let's talk about the risk versus benefit of this class of medications, these antimuscarinics or anticholinergics, because again, oxybutynin, a medication I see very often in older adults. So we know we have to be cautious again because of the cognitive concerns and other concerns that I will definitely allude to further on. But what I think is really fascinating is when we look at the evidence, we have a retrospective cohort trial in older adults who lived in the community. And this particular trial demonstrated that the benefit of treatment with an antimuscarinic like oxybutynin is almost equal to the risk of causing a hip fracture. So when you get into the dorky evidence stuff that I'm quite into, the number needed to treat for improved urinary incontinence after 90 days of treatment is 32, right? So we need to treat 32 people over 90 days for one to benefit. But how does that compare to the harm? So that number needed to harm for a hip fracture at 90 days is 36. So treatment, benefit 32, harm 36. That's kind of something that's a bit difficult to communicate to a patient. That's not what I call patient-friendly language. So let me quote for you the Cochrane review that looked at this, and this is a better way to communicate this to your patients, is that medications like oxybutynin have a modest effect. So what you can expect is in a week of treatment, you will have 4 less leaks, and you will have 5 less voids per week. That's less than 1 a day. If we round up, we can maybe say it's 1 a day. For some people, this might be really important to their quality of life because they have a social group that they're going out. Maybe they like to go out for coffee on a daily basis, and 1, 2, 5 less voids a week is really important for them. But perhaps they're already wearing an incontinence product, and now they're taking a medication that's really not phenomenal in terms of controlling their urinary incontinence, and they've got a pad in place perhaps that's going to catch any leaks. And so maybe we could discontinue this medication and avoid the potential adverse events. But again, it's all about individualizing treatment and looking at that person in front of you and deciding what's best for them. Because we have a rather vibrant 82-year-old who's still living in the community and she's complaining about her memory, I might just decrease the dose and see what happens. So if she's on 5 milligrams twice a day, I might try 5 milligrams once a day, or cut it in half to twice a day. All depends when her symptoms are occurring. So you might not always get someone off a medication, but even a decrease in dose is considered a win when it's decreasing their risk of harm.